You're listening to The Physician's Mind, raw stories and real talks with people who are striving for greatness in medicine and in life. This is where ambition meets action and where the relentless come to level up. I'm your host, Curtis Wilkerson. Thank you so much for tuning in. Let's get right into it. Hello, everybody, and welcome back to the Physician's Mind podcast. I'm your host, Curtis Wilkerson. Today, I'm here with Dr. Sandeep Rahangdale. Thank you for being here with me. Could you please share a little bit about yourself?
Great to be here with you, Curtis. Yes, I'm a physician, and I went to medical school about 5 decades ago, 1989, but I'm still young and strong, moving along in my career now in academic medicine primarily. I'm dean at the FSU College of Medicine, Tallahassee Regional Campus, overseeing about 50 medical students and PA clinical students at 3 different campuses in South Georgia, Panhandle of Florida, and in the capital, Tallahassee. So I really enjoy teaching as well as I've loved taking care of patients. I've seen over 160,000 patients in my career in preventive cardiology, internal medicine, and also some radiology training. So look forward to having a nice chat and hopefully giving people inspiration as to how they can find their path to success.
Absolutely. So let's just get right into it here. What do you think makes up a successful medical student?
It's a good question. I think that I have a lot of little sayings, and some people use metaphors because they can't come up with the right words, but I think there's some benefit of using sayings that all of us can relate to in our own personal way. And one of my sayings is, knowledge is power and quality is king. And what I mean by that is, you got to be a lifelong learner and read. There's no shortcuts. And we're in a world where, thankfully, we have a lot of high yield resources. So anybody who's in med school is familiar with them, anything from Pathoma to Sketchy to you name it. There's MedEd online. Some of these things, UWorld, that your medical school might pay for, and so of course it makes sense to take advantage of those. Other things like Anki or Sketchy, Pathoma, you might have to choose amongst those resources. So when we're in a world where you have so many resources and they're all quote unquote high yield, the idea is I spend an hour at a time, I might get 2 or 3 hours of learning, from a traditional reading a book for, old fashioned paper and pens that, we used when I went to medical school. But you have to find a way to still have the foundational knowledge, and that only comes through effort. So it sounds boring, but being a grinder is probably the best way to get through med school, and finding a way to split things up so you can have time for yourself, time for friends or family, especially time for exercise, whatever else you do for relaxation, whether it's yoga, mindfulness, spirituality, something that gives you 5 or 10 minutes a day to yourself. You're not going to have 2 hours a day to go for a walk, but every day you can find a few minutes. But the bottom line is, to be successful, you've got to build your foundation of knowledge, and that comes from hard work. And that makes it so much easier for the end goal, which is to take care of patients.
Well said. What do you think are some of the traits that you have that led to your success along your career?
I think one of the traits I have is, I'm kind of like in the tortoise versus the hare. I'm the tortoise in the sense that I just kind of figure out how to go along the way. I don't have all the answers to start, but I'm good at reading a room, at observing the ground rules, at figuring out what I need to do to succeed. And sometimes that's hard because, not everybody comes from a family where maybe, your parents were physicians, or they were scientists, or they were engineers, or they were pharmacists. But there are many other people, like myself, who I came from farm folks. I grew up in Western Pennsylvania. And, not everybody had that simple path to becoming a physician. But I think by having the skill of learning how to learn, every day trying to do better, and, that's probably some of the traits that have helped me. But I'd say the highest and best trait that I have that I can recommend to others, which is super easy to ingrain as one of your own traits, is to always have the highest standard of success for yourself. And what I mean by that is your standards of excellence. You never need to worry about competing against anyone else who's pre-med, pre-optho, pre-radiology, pre-orthopedic surgery, because if you only compete with yourself, you set the standard of excellence for yourself. And that is something that you always know you're going to be pushing yourself, being a lifelong learner, and other people will observe that. So I think having that super high standard of clinical excellence for yourself so that you can be what I call a servant leader as a physician, a shepherd or a steward of the patients you take care of, that's super critical. Because when I take care of somebody, if Curtis was my patient or his grandma was my patient, I would want to take care of her like she was my grandma or my mom. And if you do that, you're always going to use the highest standards. You think about it, it's the person you love in your family. Wouldn't you give them the best treatment, right? And what that at the end of the day requires in our very busy lives where we have information overload and so many daunting, multifactorial tasks thrown your way, I think the secret at the core of all of that is humility, and being humble is a big trait that is hard to keep when someone's always calling you doctor or calling you sir or saying, hey, it's the attending physician or dean of the campus in the School of Medicine. All of those things are nice, but that's all being a leader and being a servant to those you lead. So I think if you can have high standards, learn how to learn, and then remain humble, that would be my keys to academic success. Happy to talk about keys to overall personal success as well.
Please do.
So I have a little triad amongst my many sayings. I call it the Rahangdale Triad. And basically it's a simple triangle. The 3 points of that triad are hard work, courage, and thrift. Because if you have those 3 things in your life, and at the center of that triangle is ethics, and your ethics can come from whatever your foundation is. Some people find it in spirituality. Some people are secular humanists. So I'm not saying you have to be religious to have an ethical foundation, but that foundation of ethics will drive you. And those 3 points of the triangle, if you have courage, you're going to be willing to take risks to try to maybe extend yourself when you think, oh, maybe I can't do this. Or maybe your mom or your sister or your friends, somebody says, oh, you can't do that. So you got to have courage in life. You have to work hard. As I mentioned at the beginning, the people who succeed in med school are the grinders. They're not the people who, can party till 2 a.m., ace the test at 8 a.m. That works for a while, but it's everybody in med school is so smart that eventually the grinders are going to just, they'll pass the guys who are just trying to rely on their innate intelligence. But the third part is so key. I teach a class on personal finance for the physician to fourth-year med students as an elective. And it's all about how, as a doctor, you've worked so hard, you've maybe taken a lot of loans, somebody's helped pay your way, whatever it is, you're doing a loan forgiveness program. Even if you paid your own way, it might be $300,000-$400,000 to become a doctor. So if you have thrift in your life, what's great is that gives you the freedom and autonomy to be happy. Because doctors who are unhappy, it's really not about them not earning the keep they want to earn based on what they think they deserve. It's them not having autonomy. But how do you get into the trap where you don't have autonomy? That occurs when your bills are such high pressure on you because you just finished residency, started a practice, and now the same week you started your practice, you bought a house. The next week you buy a boat. The next week you buy, a nice set of golf clubs and a membership to the best golf, course in town. The following after that, you buy a beach home. Now you're a slave to all your bills, and you can never flex in terms of your job or your aspirations because the pressure is there that I got to bring home the bacon every day to pay for all those bills. And in my case, I had set up with a strategic goal. I had a certain age I wanted to get married, a certain age I wanted to have kids, a certain age I wanted to pay off my house. And that enabled me to leave a very successful, thriving practice that I had full time, cut it down to part time, and go into academia, become a dean of a medical school, because I was not worried about earning more money. To me, it was a matter of serving and doing things that I enjoyed, and being able to teach medical students is so much fun. But, it's of course a lot less revenue generation than if you're in a private practice. Well, today, private practice is very hard to do. And people can succeed, but they have to start humbly and with a lower salary. And then you can do really, really well, even financially. And I'm not saying people shouldn't earn good money. The point is, I've met many gastroenterologists and other specialists who earn $700,000 a year and spend $750,000.
Mm-hmm.
And so they're 70 years old and their hands are shaking and they're still trying to work because they don't have any savings. So that's why that triad, I like that triad. It's simple. And most people can relate to at least some part of it.
Yeah, a lot of good advice there with the Rahangdale Triad. Hard work, courage, thrift, with a foundation of ethics. So Dr. Rahangdale, could you share with us a little bit about your journey in medical school and residency and what led to you choosing the specialty that you chose?
Sure. So I went to med school because I grew up in a under-resourced part of the state of Western Pennsylvania, kind of industrial backbone of America that was kind of crumbling in the 1970s. And I noticed that a lot of people didn't get great medical care or they didn't have great health education. So I've always believed in patient education as a key. And so I went to med school in part because I wanted to be able to be that kind of doctor who could help teach the patients so they could take care of themselves. You come see me once or twice a year, and the rest of the time you're on your own because I'm going to look at your genetics and the things I know about you as a doc, and I'll teach you how you can change your epigenetics, whether it's lifestyle, exercise, whatever it is, so you can actually have your proteins encoding, different manner so that your muscles and cells are different. So, being that kind of a nerdy scientist approach, I initially thought I'd go to do research or, clinical research combined career. So I went to UNC Chapel Hill in North Carolina, and I just really enjoyed everything. But I particularly was interested initially in neurosurgery. We didn't happen to have the best program in neurosurgery at that time. There was some transition. And so, I thought, well, maybe I'll do neuroradiology. So I went into radiology residency also at UNC hospitals, and I got bored because I'm not a very quiet person and I really enjoy being a clinical part of the team. And I felt radiology, while it's fascinating, it's you were kind of catching the horse after he'd left the barn. So, you'd find somebody's pancreatic cancer on a CT scan or an MRI, and, maybe there wasn't much that could be done back in my era when I trained. Even today, pancreatic CA is not a great cancer to have, especially if it's caught late. So I switched to internal medicine because I view internal medicine and radiology as similar cognitive thinking. You're doing a differential diagnosis, kind of like Dr. House, MD. You're trying to diagnose complex things. But as a radiologist, you're looking at the patient's innards. And as an internist, you're looking at the patient's outards. So, you're kind of you're gathering information and things. And there's so much, revolutionary changes right now with immunology, gene knowledge is so great. We're doing gene mapping of all kinds of illnesses. We're now able to use CRISPR technology, to even change people who might have sickle cell anemia and make them, get rid of it. So many other diseases. So there's a lot you can do in internal medicine in the career. So I switched to IM, and then I went into practice. And what I found is I practiced in the stroke belt in the South, and I've been in Florida since 1997 practicing. And I ended up having an affinity towards cardiology because you had to do the diagnostic imaging and all that stuff as a radiologist as well, that you do in cardiac imaging. And so I did a fellowship in preventive cardiology. And so I practice a field called preventive cardiology, where I manage patients with stable ischemic heart disease, arrhythmias, a lot of heart failure. And I have kind of two groups of patients in my practice life. One is patients who have medical problems and don't want to have more. So maybe they had a heart attack, a stent, AFib, heart failure, and so we're trying to keep them healthy and alive. And the other group is people who might be someone young and healthy like Curtis, who, you find out that maybe your uncle got some illness, or your brother got an illness, or your mom had a stroke, and you're thinking, wow, my mom's a triathlete and she's 50. She had a stroke. What do I need to do to avoid that? So patients will come in and see me, and I'll try to do things like figure out whether it be special tests or cardiac imaging or stress tests, echoes, all kinds of other tools we have at our disposal to help you figure out what your risk profile is. So if you do need something more than just lifestyle modification, we can get you on the right medicines before you have an event.
Awesome. Awesome. Now, going back to advice for the medical students, what do you think is something that an incoming medical student, or perhaps a young medical student who wants to really excel and match into a competitive specialty, or otherwise, what do you think something a medical student who wants to succeed should know?
So I think there's two main things you should know as a medical student. First of all, because step one has gone pass fail, and there's even a lobbying movement out there potentially for step two to go pass fail. I don't think that'll happen. But most medical schools are pass fail the first 2 years. So there's very little ability to differentiate yourself objectively on a test outside of step two. Having said that, the first lesson is keep grinding hard like step one is not pass fail, because that preparation of your foundational knowledge, understanding cardiac pathophysiology or immunology, that's going to really help you excel in the clinical wards. You're going to look better in front of your attendings. You're going to answer questions better. You'll be faster at figuring out how to manage your patients. And that will lead to better success on step two, which is the objective test. And will also help you really do well clinically. And that's where people get into residencies that are competitive, is you need to have a letter of recommendation that says something like, hey, Curtis is the best student who's worked with me in the last 10 years, and I'd love for him to be my whatever orthopedic surgeon. Well, how does a attending write that Curtis is the best med student I've had in 10 years? The reason they write that is because if you're the med student who at 5 o'clock, rather than just cutting out of the hospital, you go back in and see those one or two patients who you saw in the morning, but maybe they were unstable, maybe they had a CT scan pending, maybe they had some test result waiting to come out. You go and check on them, you talk to their family, you get out of the hospital 20 minutes later, seeing those one or two people. But what you don't realize is behind you, that nurse is going to tell the attending the next day, or that family member is going to say, hey, that med student you had, I mean, that's incredible. They came back and saw me or my loved one, right before leaving the hospital in the evening, they really helped put us at ease. They told us that they kept talk to us about all the imaging results until the attending comes, but they looked over the things and everything was looking really good, and they should be reassured that the doc didn't come back in and talk to them or whatever else you might say, because again, you're not a physician as a med student, so you can't really give medical advice, in the room to the patient. But, unless, of course, your resident or attending tells you. So, but you being there, your presence makes such a difference. Showing up early on the clinical rounds, on the wards, what happens is you get letters of recommendation that are just phenomenal, your clinical evaluations. And that's, if you look at what when at programs, when they look at their rank order lists, what they really look at is how are your interpersonal skills? Are you a team-oriented person? How were your letters of recommendation? How did your interview go? How confident do they feel that you would be? Patients would love you, that residents would like working with you, your teammates, and that attendings would enjoy spending all day with you because they got to be at work more hours than they are at home. So none of those things relates to an exam score, right? But it all relates to your reliability, your interactions, how you work with others. Are you trustful? If you say to a patient, "Hey, I'll come back before I leave," it'll just let you know if that X-ray came back or not. Even if it doesn't come back, if you pop in and say, "Hey, you know what? That result didn't come back. The radiologist will probably read it in the evening, but rest assured, if there's anything, the nurse knows on the ward that, hey, if there's something that needs to be called, they'll call the attending physician." So that kind of clinical kind of craftsmanship, it evolves from your first year of med school when you're stuck just reading books and doing high yield into your clinical career. So that's a big, long answer to the first thing. The second thing is, I think, unfortunately, because of the kind of nuclear arms race to get into residencies getting harder and harder, you need to do something to set yourself apart, like research, if you can get involved early. And along with that, let's say you're thinking maybe you're a first year med student, maybe I want to be an ENT, maybe I want to be a urologist, maybe I want to do OBGYN, heck, maybe I want to be a family doc. Well, what you should do is it'll only cost you a few dollars your first year, maybe $20, $50, something like that. Join the student section of those specialties. So, the AAFP student section or the American Urological Association student section. Because what that does is, even though you may not narrow down till late in your third year what specialty you want to go into, you might have a chance to go to one or two conferences over those years. You'll meet some people. And when you write your personal statement, which is also very important applying to residencies, and when you interview, people won't think, oh, this person just wants to go into this specialty because it was what they thought of at the last minute. They'll know that here's a young lady, young man who's, been thinking about this for a couple of years, and that's okay if you're a member in 3 or 4 different student organizations that are geared to different specialties. But, you only have so many hours. And so those are kind of things where it's low yield in terms of the amount of time to join. It does cost a little bit of money, probably. Some of those associations might be free. I'm not sure, but none of my students ever complained to me about how much it costs to join a student section of a specialty. So I don't think they're too expensive, but I'm not familiar with, if it's, again, a little bit of money or a little bit more. But I think that's money well spent because it'll be low yield on time, but give you that association and help you build the networking. And then last thing I'll say in terms of research and the networking, if you're really talking about a super competitive field like dermatology, for example, or orthopedics, you almost have to try to go to conferences, meet people, present papers, find people who you can do research with. And that can be hard if you're at a very clinically based med school that doesn't have a lot of research. So you might have to, like, at FSU, we're very clinically based. We do a great job. Our students match really, really highly, but we're not a giant academic medical center like Shands, which is at University of Florida, or Moffitt at Cancer Center at University of South Florida. But some of our students, between their first and second year of med school, they'll go do research at one of those places, or at Mayo Clinic in Jacksonville, Cleveland Clinic down in Fort Lauderdale. So, you can find those opportunities, because remember, if you're going to be willing to do free labor, a lot of people are happy to have a really smart med student come do free labor in their lab. And of course, there's also virtual opportunities to get involved.
All right. Great advice. So first and foremost, grind the foundational knowledge leading up to step 1, even though it's pass fail, because those habits that you implement early on will pay off when it comes to taking step 2, when it comes to your clinical rotations and beyond. So you can demonstrate that knowledge and set yourself apart with things like research, student organizations, and likewise. Great advice. Great advice. And my next question for you is, what was one of the most challenging experiences you've had in your medical journey, and how did you overcome that challenge?
Well, I'd say probably one of the things that I can relate to is switching residencies from radiology to internal medicine, because all of us have a lot of pressure as medical students that, oh, I have to decide what I want to be. And it's kind of like you hit the third year, let's say on average in June, and by the following February, you're scheduling your fourth year, your away rotations, all of that stuff. So you're talking about 8 months. 8 months of your life to decide what you want to do for the next 40 years. Even though you might think you know what you want to do as a first year and second year med student, or maybe you did, a lot of things between undergrad and med school. The point is, until you're actually on the wards and are experiencing rotations with the kinds of doctors that you think you might want to be, it's not the same. And, you're in a different state of mind and a level of knowledge and awareness when you're on the clinical wards versus when you're pre-med or you're an M1. And so I think like that's probably the hardest thing, is how do you figure out what you like? I will tell you, for me, I thought I would love neuroradiology, but the rest of radiology didn't really excite me. And I thought it wasn't worth 4 full years of residency. And I really wanted to be a little bit earlier in the chain of, making and helping patients. Because radiology as a field happened to change in my career from when I started. It was very clinical. Everyone went down to like a dark room where there were like boards and you saw big x-rays. And so all the pulmonologists, critical care doctors, surgeons, they all came down and talked to the radiologist every day, multiple times. The radiologist would go sit in the ICU and read pediatric ICU films, neuro ICU films. So it was very interactive. And it very rapidly changed to a digital field where you never even need to know where radiology is. The radiologist could be sitting in Bermuda, and everything's read digitally and you look at it online. So radiology's kind of been taken away from the clinical fold, if you will. So while that transition occurred, or when it started, that's right when I had started residency, and that disruption and change in technology led me to realize I think I'd be much happier seeing patients. But that was challenging because at that time, radiologists had a very good life. They still do. They had lots of vacation. They worked 30, 40 hours a week, some of them. And internists worked 80 to 90 hours a week and had a lot less vacation. So, it was a big challenge to say, okay, I'm going to quadruple my workload per unit day in a sense, and switch residencies when I had already gotten married in medical school. I had a young child and another one on the way. So that was tough. But what I realized is staying true to why I wanted to become a doctor, which was to serve mankind, to help others, to be an educator for patients, so that people's grandparents, in particular internal medicine, you see a lot of people over age 50, And so, I wanted to make sure I could make a difference in people's lives, because I knew that those folks who are 50 and 60 and 70, they're the ones who may be taking care of two generations of people. And they're so vital to a family. They have a lot of institutional knowledge in terms of their work careers, their family life. And, there's such a great replenishment of energy when your patients are doing well, or when the patients come and tell you, hey, you know what, I'm not getting better, but now I know that at least I'm not going to get worse. So, you're not always fixing people, but you're helping them learn to live with their illnesses. And so I think that by pursuing what I loved, which I would have been a decent radiologist, but I ended up becoming a phenomenal internist. Not tooting my own horn, that's from feedback over the decades. It's because I chose the right specialty, and that's hard to do, because there's that pressure at home. In a sense, you'll have, maybe you have a girlfriend or a boyfriend, and your future in-laws or your parents or somebody says, well, why would you want to do anything other than become, whatever, a neuro-ophthalmologist or a pediatric anesthesiologist? Because in society, we view sub specialists as the best. But in fact, all of us, whatever specialty you go into, we're all physicians. And as a physician, you should have the skills to look at a medical complaint, and you might not know the exact treatment, but know how to go through the steps to say, what should this patient need to do next? And I think that's some of what we've lost by super subspecialization, is a lot of doctors say, hey, look, I only deal with people who need a cochlear implant. So not only is that person an ENT, but they only deal with one disease state. And that means the public has a hard time finding doctors. But it also means that you'll see a lot of doctors who become proceduralists, who are very frustrated because they work for a hospital system, and they might be getting paid well, but if they want to go see a patient, talk to them post-op, have clinic visits with them, the health system doesn't want them doing that. They say, well, let the nurse practitioners do that, because you guys make us money when you're in the operating room or in the endoscopy suite or in the procedure room. And while that's fun, there's a reason why each of us becomes a doctor. And if you're only able to do one technical aspect of your specialty, sometimes you can end up burning out in a sense, because you're just not finding what's your calling.
Mm.
So, while I would say that was a challenge for me, I think, and I ended up making a good decision. And today you see so many doctors who they change practices every year or 2 years after they finish residency. And I think it's not just because the healthcare system is fragmented and ever changing and not very patient centered. I think some of it's because people chose a specialty thinking this was the most expedient specialty to mark off the things on my checklist, rather than looking inside at their core and saying, what led me to apply to med school? That's a big event, years of preparation, oftentimes gap years, all the years in med school, residency, maybe fellowship, but what led you to want to do this rather than just becoming going into AI or going into banking or going into pharmaceuticals or something else? Whatever that was, if you stay true to that and listen to the people who are close to you, whether it's your life partner, maybe it's your parents, maybe it's, some mentor you have from church or somewhere else, some organization, those folks know you. And sometimes it's good to, bounce it off of them. And I'll say that's the biggest thing I do as a regional campus dean is I have under me the tutelage of the 3rd and 4th year medical students, and they're trying to find what they want to be. And so I have students who are even at other medical schools, they hit me up and they say, hey, this is what I'm thinking. And I can sit down with somebody and help them because I've got all those decades of experience, not just practicing, but also having physicians as my primary care patients. And so, those physicians, when you take care of them, they tell you, of course, things that they might not, everyone on the outside sees somebody who's driving a shiny car and has a great practice. But, you really see that what motivates people is it's not just the title of, I'm a whatever pediatric neuroanesthesiologist, and if that's what you want to do, you should do it. I'm not saying don't pursue a sub specialty, but I think it's an easy trap to fall into that the more I train, the more specialized it become, the more important I'll be. But the truth is, if you're an ER doc or a family doc, you can live in any town in America. You can be on Cape Cod and Martha's Vineyard, and everybody will want you because there's a shortage of you, or an internal medicine doctor, or a pediatrician, or an OBGYN. But if you, become a subspecialist, you might go to those places where you thought this is the ideal place I want to live, and there's 100 other doctors you're fighting with, and the health system owns the whole system, and they're going to really make your life miserable. So, the all that glitters is not gold, as Led Zeppelin said in a song, right? So,
Hmm.
go back to Stairway to Heaven and realize that, you got to find your calling, know yourself, and talk to the people you trust, and they'll help you. And sometimes, don't be dismissive initially when someone says, I really think you'd be a great pediatrician. You loved your peds rotation and those kids loved you. You had great evaluations. I've seen people who never thought they wanted to be pediatricians or family docs or, psychiatrists, whatever specialty. But that's where something about it clicked. And they are, of course, they might have been my med student 20 years ago. I've taught every class of students that's ever graduated from FSU from 2003 on. And, I see these young doctors in practice now. They're 30 and 40 and some are approaching 50. And, it's great seeing people happy in their career.
Wow. Yeah, it's an incredible journey there. And you mentioned how you've been working as the dean alongside some of the 3rd and 4th year medical students. So I wanted to ask you, in what ways have you been able to mentor these students while working as the dean?
Yeah, well, we have certain required things that anywhere you go to medical school, you'll have a dean of some sort or another that will work with you. But, some of that is giving guidance in terms of what electives to take. Some of it is giving feedback, on performance, of course, because I think having a self-assessment can be hard sometimes. So having somebody who can objectively try to tell you, what are you doing well? What could you do better? No student in medical school likes it if every rotation they're just told, oh, doing great. What, and, for improvement, just read more. If that's the only advice you ever get is read more, that's not very, specific or helpful. And of course, all of us know we're med students because we're not doctors yet, right? So we need to read more. But, being able to see someone's performance and guide them, whether it's their, habits of not showing up on time or procrastinating, which are easy things to fix. But if no one points that out to you, you wouldn't know that because you might have been so smart as an undergrad, you never really had to have real good study habits and you just, went right through. But whether it's something like that or figuring out, what moves you and what drives you, I can give advice and see that and try to connect you with the right resources. So maybe you want to be a PM&R doc, and you never thought about it, but your first year of med school, you had a lecture on it, you're like, wow, this is kind of cool what these guys do, functional improvements in patients so they can be more active and do more things. Maybe you don't want to be a orthopedic surgeon or a family doc, but you want to help in kind of a sports medicine way. So, you can do sports medicine fellowship after family. You can become an orthopedic surgeon, but you could also go into anesthesia pain management, PM&R, physical medicine and rehab. You can even do ER medicine, and then after ER, do a pain fellowship. So there's lots of pathways, and by knowing the different paths that people can take, I like to sit down with med students and see kind of what do they like doing. Do you like to be in the OR all day? Do you like to work with your hands? Are you somebody who wants to work irregular schedules? Are you someone who needs lots of sleep? We all have different aspects of our personalities that are important to us. And if I told you, hey, this job you're going to have to work Christmas, New Year's, and nights, you might say, oh, I don't want that specialty. I'm going to say, okay, well maybe that specialty is not for you, or maybe it is because medicine is becoming more compartmentalized. So I think a lot of it is professional career guidance. Some of it is, academic guidance. Some of it is, how to have better and more disciplined habits for success. And some of it is, I think probably the biggest advice I give is trying to get to know my students well, because I see them once a week, every week at least, their entire third year. So I get to know them. And of course, I read all their evaluations. So reading all of their evaluations and, putting into context of all the students I've had before, I really can have an ability to sit down with them. And sometimes I might be directing their clerkship director in internal medicine or family medicine or surgery to talk to them. But oftentimes, I'll sit down with them and say, hey, you know what? Your attending has mentioned this or that, and I don't know what's going on, but let's try to figure out, there seems to be a disconnect between how you think you're performing and how the person who's supposed to be evaluating you thinks you're performing. And you want to know that early rather than later at the end of a rotation. So there's no shortage of ways to help. But in medical school, some med schools, there's not a lot of kind of one-on-one time with the dean. Most med schools will require a couple of visits in a semester or in a year, in your clinical year. We have a regional campus system at FSU, so when you're at each of the regional campuses, you get to see your dean. Each campus has a different dean. And so, by getting to see my students every week, it's really nice. You get to really, really get to know them well, and kind of you figure out why they're on the journey, and you help them get to the next step.
Absolutely. And what do you think are some challenges that medical students and residents today face that maybe weren't present when you were in training?
I think the two things for sure I could say is one is, with I call it, we are a team of teams in medicine. We have lots of different teams. We work with each other, but there's a big difference in scope of practice than when I was in training. Today, when you go to residency, for example, there may be lots of PAs and nurse practitioners working as hospitalists. And so sometimes that challenge is just getting access to patients, and, so if you go into a surgery residency somewhere and you can only do 10 appendectomies in 4 years, you're not going to be a great surgeon. But they're going to tell you, hey, you could do a colorectal fellowship, spend 2 more years, and you'll get to do more appendectomies. Well, that's a wonderful virtuous cycle for the academic center, because they get you at a lower cost where you have very restrictive hours. You're under a program, but you'd much rather go to a program where they say, hey, you want to take an extra weekend call? There's going to be 5 more cases on Saturday. So you want to be able to practice your trade in a training environment. So if there's too many people training or working in that setting, sometimes you can have difficulty with access to enough clinical care opportunities. When I was in medical school, you could do 30 exams, of a particular type in one day in the clinic. And today, a med school might require 3 on the entire rotation of that exam, because there's not, there's many more learners, many more schools, many more disciplines. So trying to, you have to be able to take incentive and be one who's willing to say, hey, do you tell your attending, I want to be able to do more. If I can do a lumbar puncture, let me do it. If I can put in a chest tube, if I can put in a central line, the more, if I can do some, OB ultrasound on my OB rotation, you say, I don't mind coming in at 7 o'clock to the OB lab and, do some OB ultrasound or whatever. You try to take advantage of that, learn those tools, POCUS, point of care ultrasound. There's a lot of new technologies that there's a lot of different learners fighting for access to using that technology. So I think that may be a difference, is that we have more technology, but we also have a harder time getting access to the patients. And again, I'm talking a general average. Maybe another thing that's different is, the concept of how medicine is delivered. We used to have, when I finished medical school, 80% of doctors were in private practice. Today in America, it might be like 30%. So that's a big shift, almost, a complete inversion. So most physicians are working for hospital systems, hospitals, other entities. So I think that being able to learn a little bit about the finance of medicine is an important thing when you're maybe your fourth year med student. You don't need to do it sooner than that, but kind of keeping your ear to the ground. You can find a mentor who can help guide you. What's it really like to be a gastroenterologist or a pulmonologist or an immunologist, allergist, an immunologist, or whatever specialty you're looking at. That can help overcome the fact that you may not have as much access to patients, so you may not see as many of those things. So how do you know if you'd like gastroenterology if you've never seen an endoscopy or an ERCP or an endoscopic ultrasound, fine needle biopsy through the wall of the stomach into the pancreas, pretty amazing, cool things. But if you never see that in your clinical time, you wouldn't even consider that for a career, right?
Mm-hmm.
So I think, trying to fight to make sure you're able to do more, because many times the supervisors you're working with also they're being pushed by RVUs, relative value units, so their productivity is kind of pushed more on them. So they may not feel an inclination to take more time to teach you if they feel you're okay with that. But if you tell them from the first day, you say, hey, anything I'm doing wrong, let me know. I want to, do better. Anything you see I can improve, please let me know. And by the end of that first week, if you're there on 6-week rotation, you say, hey, how am I doing? And if they say, hey, you're doing well, you just started your third year med school, say, that's great. Anything I can do to see more, if one of our patients is going to the cath lab and you're okay with it, I'd love to go, in the cath lab with the cardiologist and watch the heart cath. If one of our patients is going to get, an endobronchial ultrasound to kind of like a little GPS game to find a lesion in the lung, and, they can, look at it with EBIS, say, can I go with the patient to the pulmonary suite? And so try to take those opportunities to follow your patients, because at the end of the day, you'll learn from the patients. And if you're grateful to the patients and you're learning from them, you're going to get, I think that hasn't changed from my time to your time.
Mm-hmm.
It's the patients who teach you, the patients who refuel you, the patients who you're there for, who you serve, So I think if you have that mindset of, hey, I'm going to be very humble, thankful, appreciative, that these patients are allowing me as a student, they're giving me, I'm listening to their lungs, I'm pressing on their stomach, they might have a, wound, and I'm, looking at their wound, that's kind of humbling to be able to be part of that care team. So always remember it's a privilege, but also realize that your attendings, your supervisors, the system is so haphazard and, hectic, that unless you are taking ownership and showing that kind of, hey, I want to do it. You take the opportunity to any incentive you can have. Might mean that your incentive is if you come at 6 a.m. they'll let you see something. Hey, that's great. Say, you might think that's a penalty, but it's really not. If someone says if you come at 6 a.m. you can go watch the patient go to the OR, you wouldn't have gotten the OR otherwise, right?
Mm-hmm.
So, even though it might seem like you're stretching your time, that's where you're really going to learn is, by the patient and by, watching the procedures and the kind of the care.
Okay. So increasing mid-level providers limits access to patient care for the student or the resident or the practicing physician potentially, but it falls on the individual to make the effort to do more, seek out new opportunities, even if it requires staying late or getting up early. And the decline of private practice over the years, more physicians joining hospital groups, again, gives the individual the responsibility of learning more about medical finances and exactly how they're going to navigate the changing field. So again, great advice there. And Dr. Rahangdale, as we wrap up this interview here, do you have any last pieces of advice you think that align with the mission of this show, which is to engage the curious mind as they optimize their journeys of lifelong learning and self-improvement in medicine and beyond? Any last pieces of advice for that?
Sure. Thank you for listening to a lot of different topics today we discovered, but I would say maybe the most important question I'm asked by many medical students and residents is, how is it that you're able to stay happy as a physician, and how do we avoid being unhappy? At the end of the day, you're a super smart person who's at the top of, the food chain in a way, in terms of career, yet there are many people who are unhappy. About 25% of the medical students and residents surveyed admit to having either anxiety or depression at one time or another, and that could be an underreporting. So I think I'd like to end by giving you my tips to, how to maintain happiness in a medical journey and in your career. One is to always have an awe at the natural world. So if you're kind of a curious person, you look at the stars and you're like, hey, that's kind of neat. Or you look at a river or a mountain. It's the same thing in medicine, right? Every day there's 10,000 journal articles published. So keeping an open, curious mind with a love of learning new things, that will help you stay happy. The second is, I would say my tip would be to be happy on the journey with your patients, as I mentioned here earlier in the show. Learn from them, let them recharge your batteries. And the third thing I would say is understand that, again, while it's a trite saying, that perfection can be the enemy of good, don't be too hard on yourselves. I tell my patients and others, if I'm having a pleasant disagreement with an ICU nurse on whether to give medicine A or medicine B, and the nurse is telling me, no, the patient would do better with B, and I really think they need medicine A, rather than it being an argument, I view it as a learning opportunity. And I always say, you know what? I'm thrilled if I'm wrong. If I'm wrong, that's great because then I'll learn something from that opportunity. So in the future, I'm an even better doctor. So don't be afraid of being wrong or making an incorrect clinical decision. As long as you're trying to learn and improve, you're going to keep getting better and you're going to be right way more than you're going to be wrong. But you can't put that pressure on yourself that I can never be wrong. So go on, look at it as a journey of learning with your patients. And if you communicate well with them, they will also understand. You just tell the patient, you say, I'm not sure what's going to happen if we give you this treatment plan. This may or may not work, but we're going to try it for this reason. You say it to them honestly, maybe they don't get better. The next morning you show up and you say, you know what? You tell the family member, remember we talked yesterday and, your mom's not getting any better, so I think we're going to have to change course. Nobody's going to fault you for that. But if you think you can never be wrong, you always have to be right, you can be your own worst enemy. And that's one important lesson for physicians we've seen, NPAs as well, nurse practitioners getting their DNPs who have taught clinically, that, we are really hard on ourselves, but we need to learn that when we're not right, that's okay, but we got to find the lessons, from it, whether it's doing root cause analysis or however your mechanism is to find out, what can I do better next time? And if you do that, you're going to be a happy doctor.
All right. Dr. Rahangdale, thank you so much, sir.
Hey, you're welcome. Thanks, guys.